All right, well, good morning, everybody. My name is Doug Hoffman. I'm filling in today for Dr. Stephen Schaff for this ultrasound case series that we do every other Friday morning. This is the second case of our new season, the first part of the season going from August till the end of the year, where we have faculty present ultrasound cases showing their complete exam, their protocol and report. And then the second half of the year, we have fellows do the same. So today, our case is that of a mallet finger by Dr. Altamash Raja, who is currently an assistant professor at the Department of Rehabilitation at Rowan Virtua School of Osteopathic Medicine in New Jersey. He also serves as Associate Program Director for Inspira Health Physical Medicine and Rehab Residency Program. He completed his PMR residency at Johns Hopkins, where he served as chief resident. He went on and did a primary care sports medicine fellowship at Geisinger. Dr. Raja, we were talking earlier, integrates ultrasound fairly universally in his practice. So we're happy to welcome Dr. Raja today for a presentation on a mallet finger.
How's that look?
Looks great.
Good. Hey, thank you again, Doug. Yeah, I really appreciate it. And it's really a privilege to be here in front of you guys today. And as Doug mentioned, my case is about a mallet finger. So let's get right into it. So unfortunately, no disclosures as of yet for me. But the objectives, if you've seen any of these talks before, are going to be much of the same. Just to remind you guys, we're hoping to review a complete diagnostic ultrasound digit protocol. We'll talk about some of the differences in that and what that actually means. We'll discuss the ultrasound images as highlighted in the protocol, but only the pertinent for mallet fingers. So I'll present some of the sonographic findings for that as a case I saw earlier this year or last year, and compose a diagnostic ultrasound report, which is how we're going to end this case, and then some time for discussion. So some notable prior presentations, I think worth your time. A lot of time has been spent on the volar aspect of the hand. So I'll spend very little time there, but we will touch on that. So I encourage you guys to check these out just to get a comprehensive understanding of not only the ultrasound findings, but also some of the pathologies that you're likely to see. They say it takes a village, so I certainly want to, give a shout out to all my mentors, particularly my PM&R sports mentors, Dr. Justin Tunis and Dr. Brandon Tunis, who feel the brunt of my questions on a daily basis, whether it's regarding sports and ultrasound. And then also to some of my peers, Dr. Alex Shostarovich, who shared my passion for ultrasound throughout residency and allowed me to get several hours of practice in with him. And I think that's what made me a better sonographer and a better clinician. And then certainly Dr. Jamie Doherty, who has really pushed me over the last year and a half to just be a better educator. And hopefully I can share that with you guys today. So this is a case of a colleague who is a physical therapist and a 34-year-old male who was playing flag football on Thanksgiving Day and doesn't really recall exactly how the injury happened, but complained of, by the time I saw him the following Monday, 5 days of pain and swelling in the left ring finger. He also said that he had inability to extend the distal phalanx. Again, he wasn't sure if it was catching a ball or going for a flag or whatever that might have been. But as you can see on exam, that left ring finger on the bottom right here is quite swollen with quite a bit of ecchymosis as well. He was also tender to palpation, particularly over that DIP. No active extension of the DIP, and his passive extension was normal. I should mention that he had gone to an urgent care prior to that, and so they put him into a splint. So some of the exam that we deferred just for the sake of not resetting the management, which we can briefly touch on later. But finger flexion, pretty much at all other joints were normal. DIP was limited, as you can see in the top right here. And flexion extension was preserved 5 out of 5 at all joints except the DIP, which we elected not to test. Doug, you can see my cursor here, right?
Yes, I can.
So we always want to correlate with any prior imaging available to us. Lucky for us, we were able to acquire his imaging from that urgent care that he had. And we have your AP and a lateral. And this lateral really does a good deal of justice to this. So if you look at this DIP, you can see that there's a bit of a cortical irregularity, a little step off coming up here, subtle displacement, but not significant enough. Perhaps a little bit of articular compromise as well. And so we can see that disruption in the bone that was correspondent with his pain that he had, maybe a little bit of soft tissue swelling as well. But, x-rays are really important. We know the radiographs are highly sensitive when it comes to bony pathology. So with that combined with ultrasound, we can get a good picture. So we ask ourselves what the role of ultrasound is, specifically in mallet finger injuries. And I like this study by Wang in 2017, mainly because of confirmation bias, but also because they do a good job comparing with some of the other common imaging modalities that we use in musculoskeletal and sports medicine. And as you can see here, this was for closed mallet injuries, and ultrasound was the best or tied for the best imaging modality. And I would argue when you look at some of the other limitations for the other imaging or advantages of ultrasound in terms of point of care and cost, it should be our #1 thing to go to. For scanning considerations, we always want to be mindful of what transducer we're using. Everybody at this point probably has their quote unquote workhorse transducer, which is for me, it's the 15.4. But I spend a lot of time using the 19.5, which is my small footprint. Some of you guys might have a hockey stick, but this is my replacement for the hockey stick. It's 19.5. I think this does a really good job when we're trying to isolate the finger. Some of the prior guests have mentioned how, keeping contact when you have these quickly angulated, quickly turning surfaces, it's a bit challenging to keep that. So I think a smaller footprint makes it a little easier for me to do that. For patient positioning, seated in that quote unquote hand tray position, as Dr. Betcher mentioned before, works really well. If they can't, they always be in supine or recline or whatever, as long as you can keep the wrist flat. And I like this technique where I'll throw a little chuck or paper towel if I'm trying to isolate the finger. As I mentioned, contact is really, really important. And if you have other fingers, especially if they have a larger body habitus and swollen fingers. So if I'm trying to isolate, this works well. On the volar aspect, if I'm considering any type of intervention, and they might be inclined to curl up their fingers if we're doing some type of injection, this is something that I find to be helpful. You can consider a water bath, primarily for contractures, but in this case, we don't need to do that. So for our complete protocol for the digit, as I mentioned, there's really no clear consensus in terms of guidelines of what this might be. We have some guidelines of what a complete examination looks like. And so you might see some variability, but generally prior speakers and most people that I've seen have agreed that, these are the structures that we want to hit. I like to think of when I'm scanning really any region in kind of, anterior, posterior, different parts of the body. And so I'll break it down into dorsal, volar aspect, and look at the bones and joints, which we can and likely should be looking at from both the dorsal and volar aspects. So for the dorsal aspect, where we'll spend most of our time, that extensor tendon and the different parts of that, using dynamic assessment when appropriate, looking at the sagittal bands, really scrutinizing that central slip insertion and then terminal tendon as well. On the volar aspect, we look at the flexor digitorum, both the superficialis and fundus, A1 and 2 pulleys, and the digital nerves and arteries. And as I mentioned, the bones and joints you want to look at from both sides. You want to expand it a little bit further. You can consider the collateral ligaments when you have those sprains and finger jams. We can also look at the lateral bands. I find this to be a bit challenging and wasn't part of my protocol, but as I've prepared for this, I think I'm going to start inserting it a little bit more. And you can do a further evaluation of some of the other pulleys further down the hand. So getting into our scan here, this concept of zones has been talked about before, and I think it is worth mentioning. We want to be able to characterize the proximal extension of the injury, but the other interesting thing about the extensors of the hand on the dorsal aspect is that they don't function in isolation, and there's this synchronized coordination with some of the intrinsic muscles, and together they're going to cause a lot of that distal phalanx extension, or really just extension of the fingers. And so it's really important to trace it back as far as you can. And so I find that just starting in that on that fourth dorsal compartment of the wrist is a good place to start. And that cursory scan, as I slide distally, only takes a few extra seconds, but gives us a good lay of the land. So I'll play this clip for you. We started in the fourth dorsal compartment, and I come back all the way down into right at that metacarpal head, which is where I'm going to begin the next scan, just to see what that tendon looks like as it breaks off into the individual fingers. So throughout the exam, on the bottom right, you'll see the orientation of the transducer. and we'll keep that consistent throughout. So one more time, I'll play that for you guys. We're starting up at that fourth dorsal compartment, and we scan distally, looking at that, hyperechoic tendon as it breaks off into the different individual tendons as it goes to the distal aspect. You see that hyperechoic bone, and this is that fourth metacarpal head that we're getting to, and here's your extensor tendon. And from here on, we're going to begin the rest of the scan. You're also making note of some of the digital neurovascular structures to see if there's any distension or anything that really pops out. And if it does pop out, then you can do a further evaluation. But for this now, we're going to keep it focused here. So we pick up our scan. I should mention that, what we did there was in short axis to the tendon. So again, as you can bottom on the right, you can see this is short axis to the tendon. And this picture is a really good depiction of what we're looking at here. So on the center portion, you have the extensor tendon that we're looking at, and you have the sagittal bands coming across. You can see some anisotropy where it appears anechoic here because the transducer beams aren't perfectly perpendicular to that. And the sagittal bands are largely intact. Underneath that, you have the fat pad and the capsule. And again, that bone is going to be nice and hyperechoic. We're not seeing any irregularities. Dr. Betcher previously mentioned the importance of kind of evaluating this for a certain pathology like boxer's knuckle, you guys might have heard about. So that's what we're looking for here. If you were concerned about something like that, then you can always add a little dynamic examination. And that's really the best way to get a sense of what these sagittal bands are doing and how they're behaving. So again, they're a bit more hyperechoic. And in this view, this is a bit challenging. So the patient's going to have to dynamically flex and extend. Doesn't require a great deal of extension, but what you can see, the transducer is going to be more of an axial plane we're looking at right over the metacarpal head. And so I'll play that here for you. And as soon as they flex, you can see how they get a bit more taut, but really focusing on that central extensor tendon, which is more hyperechoic and stays midline. And as I mentioned, Dr. Betcher previously talked about how it has a bit more, it favors an ulnar subluxation if you have an injury. But to review that, you can go back and listen to his talk. While we're here, we can start to appreciate the articular cartilage a little bit as well. As you might recall, this is hyaline cartilage, so it's going to be anechoic largely. And we can start to pay attention to any focal cartilage defects. We're still looking at the bone as we're going from proximal to distal to see what's going on, if there is anything that we need to be concerned about, and if so, we can expand on that evaluation. Moving along, we're going to rotate that transducer to 90 degrees. And this is my way of really getting a good sense of that articular cartilage and looking at that MCP joint. In order for you to do that, we're going to have to get a little bit of flexion at the MCP joint. And so in order to keep this individual with the DIP and extension, this is how we ended up doing it. This is not that person. This is just a model to give you a depiction of what it looked like. But now we have our transducer still at the MCP joint. We're really paying attention to that articular cartilage, looking for any focal defects, any erosive changes in this area, any subjacent bone cortex thinning that might suggest that there might be an inflammatory erosive process going on. We look at the synovium to see if there's any thickening, hypertrophy, any change in ecotexture, which we don't see at all. And so those are some of the things that you're looking for. You can see that here. We can also get a good sense of what the overlying extensor digitorum looks like, but the next picture is going to be a better visualization of that. But here I'm just trying to get a sense of what that joint looks like and if there's anything that I need to be concerned about. I think the MCP in particular needs to be looked at very closely. There are a lot of inflammatory arthropathies that have a predilection for really making some changes at the MCP joint, and so this is a place that I like to spend a little extra time looking at. And I do find some of the younger patients that we see that have some inflammatory changes that we pick quite a bit of them up here. So now we'll have the patient go with that hand flat so we can really scrutinize that extensor digitorum tendon. We're still being mindful of the joint and the bony cortex underneath and looking at the synovium. Again, looking for any effusion that might be descending that recess or joint capsule, but really paying attention to the extensor digitorum, which is overlying up here, looking for any type of laxity, any type of wavy appearance that might suggest, a terminal injury and proximal retraction. But what we can appreciate is that fibrillar pattern that we're accustomed to, relatively hypoechoic around, compared to the surrounding structures. But I think that's just because of the thickness of this tendon overall. It's a very small tendon relative to some of the other structures that we routinely look at. But we don't see any disruptions in the tendon, no focal defects or no significant thickening. So we're cruising along, going a little bit distally, staying in that long axis to the phalanx. We're going down to the PIP joint. And here we're going to start appreciating that central slip. And so you can see that overlying tendon comes and attaches at the just past the PIP joint at the middle phalanx. And it has a bit of a broad insertion. Still overall relatively hyperechoic, but hypoechoic due to the surrounding structures. Remember, this is it's all relative, and because the bony margins are so close that this probably appears a bit more hypoechoic and so just below the hyperechoic subcutaneous tissue. But we are looking for any disruptions in this tendon. So, any either disruptions in the tendon fibers or any disruptions in the bony cortex that might suggest an avulsion injury of some sort. We're also looking at the underlying joint a little bit more closely, looking to see if there is any osteophytes, again, any erosive changes, anything that might be causing distension into the joint, which we don't see here. This is another joint that we want to pay attention to. I think probably in traumatic instances, we've all learned about, you might have a dorsal dislocation that might cause rupture of this and, some of the other accompanying tendons that can keep this. But, obviously you would see that exam, but you might look for any secondary signs and you might see a lot of changes in the bone. But overall, this looks relatively healthy with respect to the tendon and attachment. We'll continue down, going distally to the DIP joint. Now, this is not our patient, but I wanted to give you a sense of what normal might look like. So staying in long axis to the DIP joint, that's what you're seeing here. This is that mid-phalanx P2, and then you have the distal phalanx on the left. And you can see that terminal tendon, again, overall very, very thin. Still has a broader insertion when we get to that, base of the distal phalanx. But same concept, looking for any possible disruptions that we're looking at that you're going to see in a moment when I show you the pathological finger that we ended up seeing. But we don't see that in normal. Overall, the relative thickness and echogenicity of the tendon is preserved, and it's been consistent throughout from proximal to distal. Again, making note of any changes in any bone cortex or any distension in the recess or the cartilage, and we don't see that in a normal finger. However, when we look at our patient, what you can start to appreciate when you compare to the prior one, right off the bat, you'll notice how thick this extensor digitorum, this tendon is, that terminal tendon. And so compared to the last one, where I mentioned it was very, very thin throughout here, you can see it's quite thick throughout here. But when you look at the distal fibers attaching at that base, we don't see any disruptions there. So it's relatively still intact there. But what we do see is a clear cortical irregularity and almost a step off is what we call it, depending on which plane you're looking at, with a 8 mm displacement. We called it a dorsal and a proximal displacement that you can see. We measured this in long axis. A little hard to appreciate the actual joint here because you have, this posterior acoustic shadowing, but we can look at that recess to see if there's maybe a little bit of a fluid. I would probably say that this is because you don't see a lot of this distension, and that's going to present at this anechoic extension coming back up here. But other than that, no significant changes to the bony architecture, neither proximally nor distally. So one thing we can do here, and really as indicated, you can do anywhere, but for our purposes, we wanted to go ahead and make sure we throw a Doppler on here. And several people have talked about, because you're so superficial, you want to be really mindful of how much pressure you're applying so you're not ending up, getting any false hyperemia that you might end up calling. And so we don't see that any increased signal, no hyperemia through here, suggestive of any inflammatory process going on. But this was relatively straightforward in terms of what we expected to see, but we want to be comprehensive and look at that. And so we don't see any internal flow in that long axis. So staying in that DIP, here what we did is we rotated 90 degrees, and now we are short axis to that tendon, which is a little hard to appreciate. This is going to be just the distal fragment that you're end up seeing. And we can also see where that the initial donor site, or you can see that cortical irregularity in the bony cortex. In the next slide, I'm going to show you guys a video of a proximal distal scan so you can really get a sense of the entire injury of that fracture fragment, and you can see some of that tendon as well. But you could also choose to measure in this one. Ultimately, we ended up doing long axis just to see. Really, it's a dealer's choice there. But we're trying to, get the images as much as possible. We also see some soft tissue swelling up here, increased thickness there of the subcutaneous regions, and you can comment on that as well. You can throw a Doppler on here too if you choose to, and that's always an option. So this is that video that I talk about. So I like to, get as many clips as I can, and I can go back and always pause and save the images that I really like the best. And so I'll start just proximal to the MCP, and we'll play it for you. We'll start proximally. It's going to end up distally. And you'll see that just as soon as we pass that PIP joint, you'll see a lot of cortical irregularity there. Let me do that a little bit slower for you as we go down. So we're going to pass the MCP joint, PIP joint right about here. And then immediately afterwards, you'll see a lot of, you'll see another bone fragment coming superficial. And we'll do a lateral to medial scan for you to get a sense of so we can really characterize what that fracture looks like, and you go all the way distally. So we started proximally, we end up all the way in what that prior image showed, just past our fracture site, to get a sense of the extent of the injury and what that looks like, when we're looking at ulnar to radial. And so this is the video that I was talking about, right? This is an ulnar to radial scan in long axis to the image. I've started doing this anytime I'm looking at any type of tendon injury. Probably doesn't matter as much for a small tendon like this, but when we're looking at, an Achilles tendon or a patellar tendon that have a relatively a broad tendon, and sometimes, I found that people will have pathology only the medial aspect or lateral aspect. And just to be very precise, especially if you're considering some type of biologic intervention, we can always favor that area. So, but I still like to do it pretty much every tendon that I do, and it just gives me, again, a more clear picture. Like I said, I can always pause and take just still images and the ones that I like the best. So as we go ulnar to radial, as I mentioned, you'll see that fragment starts to appear more distally. And then as we go more radial, you'll see the entirety of the fragment. And that was consistent with that short axis image that I showed you, that on the radial aspect, you could see the fragment, but you couldn't see that. So I think that this kind of gives you the entire 3D view of what's happening and the injury. So for my report on the dorsal aspect, I said the extensor digitorum is thickened and hypoechoic at the terminal insertion, with an avulsed bone fragment off the distal phalanx. An 8 mm dorsal displacement is noted. No hyperemia is noted. Sonopalpation is painful. There is no disruption in tendon fiber continuity or icotexture proximal to the DIP joint. Upon dynamic assessment, no subluxation or displacement of the extensor digitorum is noted over the MCP head. The metacarpal joint appears normal. The PIP joint appears normal. So I mentioned earlier the lateral bands that weren't initially part of my protocol, and full disclosure, I didn't end up doing, but I'm thinking now that this is something that is worth adding to it. It certainly takes a little bit of time and actually ends up being a little bit challenging. So I'll show you a picture of the anatomy in the next slide, but what you can see is if you slide in that central slip, when you have that, if you just slide the transducer a little bit more, either ulnar or radial, in this case more radial, and then tilt back more ulnarly, you're almost in this parasagittal, oblique view where you're looking at, and you can see the fibers of those lateral bands going over the PIP joint. And as you go from proximal to distal, it gets to be a little bit more challenging to capture the entirety of that tendon in one view. And so here, a video can, in long axis tracing from proximally to distally can be helpful. And I think the reason for that is if you look at this image right here, if those bands, right, on the proximal aspect, the finger is almost always going to be broader and wider. And as we get for further distally, they're going to, angulate and narrow down. And so, depending on where you are proximally, you can catch the bands, but keeping that transducer contact gets to be a little bit challenging. Fortunately, the ulnar side was a little bit easier, at least in this sample image that we took. And so again, we have that parasagittal tilting, more radial. And so this is the ulnar sided lateral band, and you can see the entirety of the band going from proximal to distal. Again, looks very similar, but a lot thinner overall. You can see the fiber, no disruptions in continuity, and good fibrillar pattern. So moving on to the volar aspect, to be comprehensive, we're going to look at this as well. I'm not going to spend a lot of time, as I mentioned, a lot of good prior studies here. But here's when I'll switch back to the 15-4 so I can get a wider view of what's going on. I have a pretty good sense of what's happening with this patient already, but we want to get all the information we can. And so I'll start at the metacarpal joint, and again going from joint to tendon. So we'll look at the MCP joint. Again, similar concept when we're looking at these joints, looking for any distension of the recess, a lot of fluid coming down. We're looking at the volar plate, at the synovium to see if there's any issues, any erosive changes or any irregularities in the bone. Remember the flexor digitorum tendons, the profundus is going to be deep at this level, and superficialis is more superficial. You can see the hypoechoic pulley, A1 pulley, and then the A2 pulley, which has a much larger footprint, but it's a very thin band that they seem to be intact. You can add dynamic assessment as you see fit. But the reason, even in the extensor or the flexor part, we didn't add the dynamic assessment. This guy was a physical therapist, did a lot of manual therapy, and we decided that he already was 5 days of extension, and we weren't going to aggravate that tendon and potentially compromise his healing. But you can add that where you see appropriate. So pulleys can be a little bit harder to visualize, particularly in long axis to the tendon, but short axis to the pulley, and those are the thin bands that this animation depicts here. Sliding a little bit distally here, we can capture the PIP and DIP joints simultaneously. Looking again, similarly, the volar plate to me appears to be much more like a shark fin. I know there was some debate in the prior presentations of which NFL team logo it looks like, but to me, it just looks like a shark fin on the side. But still looking at similar things, looking at the joint recess to see the distension, looking at any cortical irregularities in the joint and the bones. Note that the flexor digitorum superficialis will attach and the profundus continues on, as some of the prior guests have talked about. But you can see that, here, nice and hyperechoic, but it becomes hypoechoic as it takes different angles, and you get a little relative anisotropy. But you can always, if you're trying to scrutinize this further, do some heel toe maneuvers to capture whatever aspect of the tendon you're trying to get the best of. So I like to, for my short axis, just to be, efficient, I'll start at the A1 pulley. So again, this is starting at the A1 pulley. You can see that it's relatively hypoechoic, almost borderline anechoic. And remember, this is long axis of the pulley. And this is probably the best, the short axis is the best image for me to get a sense of, are there any disruptions in the tendon, because, they appear to be nice and hyperechoic. And this is going to give you that relative positioning that I was talking about, where that you can see the flexor digitorum superficialis wraps around and then attaches proximally, and the profundus continues going. So we start proximally and we end up all the way down, just past the DIP joint of the volar aspect. And you can see the different pulleys that we go over. As we pass the tendon, you have a little hypoechoic band that comes up, and there's another one right there. And you can see the tendons wrapping around. And again, we're commenting on if we see any disruptions in tendon fibers, any loss of any focal anechoic or hypoechoic changes, we'll comment on that, and we don't see any of that in here. So for my report on the volar aspect, I said the flexor digitorum superficialis and profundus appear normal. The A1 and 2 pulleys appear normal. The volar MCP, PIP, and DIP joints appear normal, and the volar plates at the MCP, PIP, and DIP also appear normal. So putting it all together for our ultrasound report, this is something that I've adopted, I think, from a previous guest who mentioned how they just start putting their whole scanning protocol, and then they can just comment on the things that they find to be abnormal. And so I like to list that out here. Any comparison images that we have, the indications and the device. I'll list typically the system that we have, but here for our transducers. And this is how I think most people like to list it out here, just going by structure approach. These are things that you've already seen before that we've commented on. So we comment on the different findings on the extensor tendon, and going through some of the things that we found. And then lastly, I'll give my impression on, what I thought this was: an avulsion fracture off the distal phalanx with accompanying extensor tendon injury at the DIP joint. And then adding, what my editorial is toward the end, that this is consistent with a bony mallet injury. And so in summary, I think we can all agree that ultrasound has an extremely high diagnostic value for finger injuries. But I think something that I'm really passionate about, and I make a point with my trainees, is that, this is an extension to our physical exam. And so we have to use it as such. And for me, this is my stethoscope, and I like to use it every single day, but I am trying to answer a question. Nevertheless, we do have to stick to a protocol because that's going to minimize, any possible missteps and pathologies. And a lot of times, for somebody like me who's earlier in their career, you don't know what you don't know. And if you don't stick to a protocol and you jump right to something that's as clear cut as this case was, then you're likely to miss something that might be masquerading as that type of injury. And, I have seen that from time to time. And so these are my references, and thank you for your time.
All right, Dr. Roger, that was excellent. Very well organized and hit all the points in detail. I mean, the reality is this talk that you gave, which showing the detail that you did, really is a new way of ultrasound. I mean, when I first started ultrasound, we could see some of those structures, but not at the detail we can see now. So in the beginning of your talk, when you showed that high frequency linear array probe, or it could be a hockey stick probe, that's becoming more standard on various machines and allows us to see these structures in the detail that you presented. I really liked your technique of a towel, wedged between the fingers. That works well, and you're right. Sometimes when you're just sort of free forming, it's easy to slip the transducer off. And so I like that technique. I also kind of want to point out with your images that, for everybody who does fingers, that many of your images had a lot of gel on it. And so you're able to lighten your pressure and see the full contour of the fingers. And so anybody who's doing a lot of hands and fingers, that's a good demonstration that you do need a lot of gel. And you did mention very quickly using water, and you can, but I do a lot of fingers, and it's a mess when I'm done because I'm constantly putting more gel on. And we actually have a gel heater, but we do have one gel if I know I'm going to be doing a lot of fingers that we don't put in the heater. In fact, you can even cool it a little bit so it holds its form a little better because the warm gel just seeps right off. My protocol, same as yours. When I first, started ultrasound again, I see a lot of fingers, and I was like, okay, well, I need to do a complete exam. What do I do? Well, like my protocols, I start with the joints. And so like you, I always start, even if I'm, rule out FDP rupture or something on the volar side, I start dorsally, and I do exactly what you do. And I start scanning the joints and long axis, MCP, PIP, DIP, and just go successively. It doesn't take very long. You now are getting the criteria for a complete exam, and you find things in the joints, as you mentioned. Kind of unlike the volar aspect of the finger, as you demonstrated, the dorsal aspect of the finger, most of the images are in long axis because the tendons are so thin. So unlike the volar aspect, where that short axis proximal to distal video that you showed so well, and you can see some of the details a little better, that's very difficult to do, especially in the normal state on the extensor side. And so again, as you demonstrated, I tend to go short axis more at the MCP joint. So if I'm seeing MCP joint abnormalities, I'm always doing that in orthogonal views. And then of course the sagittal band is a anatomic transverse, which would actually be long axis to the sagittal band. But you're right, just like you demonstrated, I'm looking at the tendons in long axis because they're so thin. I don't see very many mallet fingers injuries. I've probably seen half a dozen. I don't I laugh a little bit. It was your physical therapist. My best bony mallet was a partner of mine. I said, hey, can I scan this? Because I need it. Because the reality is you don't really need an ultrasound if you see an avulsion fracture and you have a mallet deformity, but the images are great. And so some of the mallet finger I see is either something chronic, and they want to know, is this a DIP contracture and osteoarthrosis, or is this a soft tissue mallet that hasn't healed? And I find those really difficult because that terminal extensor tendon is very thin, and it gets even more thin if it has a subacute to chronic tear. And so, and what I find when I'm doing my exam, which I'm sure you do, is when I'm scanning the extensor tendons and long axis, I'm constantly moving the joints. And so I can see some motion in the tendons. And so for me, when I'm looking at a chronic soft tissue mallet, it's the absence of visualizing the attachment of the tendon that allows me to make the diagnosis. And I might not see the proximal stump of the tendon because that may have been scarred down to the bone itself. So just a little caveat there that sometimes the chronic soft tissue mallets can be very difficult. Not only are we able to see these things in incredible detail, but the other thing we're doing when we have these high frequency probe is we're learning injury patterns, and we're supporting the norms or we're refuting the norms. And for me, this area is most highlighted at the PIP joint. So I find probably the biggest utility for me on the extensor side of the finger is when I get a jam finger or a PIP joint injury, and I want to know if the central slip is intact or not, because that changes everything. It changes from splinting and extension, which in itself is going to have repercussions, versus if I have an intact central slip, then I can move it. Sometimes we're taught, or I remember way back in my training, if you see an avulsion fracture of the volar plate at the volar base of the middle phalanx, you got a splint and extension. Well, unless it's a big fragment with subluxation, these are all partial small avulsions, and they don't, need to be splinted. In fact, that increases the risk of a contracture. So ultrasound has really kind of changed my thinking of how we manage a lot of these injuries because we can see it in such detail. That was a really, really good, not only overview, but a detailed overview of the extensor side. You hit all the important points. So that was really excellent.
Thank you, Doug.
I don't know if anybody has any comments, or Altamash, if you have any other comments you.
Yeah, I wanted to ask you, Doug, how often do you look at those lateral bands? If you do, I know you mentioned you're not doing a ton of that, but I,
Yeah,
really,
I find the lateral bands difficult because there's variability in the lateral bands, and oftentimes some of those bands that you showed are almost embedded into the dorsal hood. And so they're not necessarily discrete. And some people they're discrete and some people they're not. And so the only time I find the utility of the lateral bands is when I get a snapping finger. And so, or a trigger finger, for example. And one of the differential diagnoses of a trigger finger is snapping lateral bands. And in that case, again, clinically, they hyperextend and then go into flexion versus just flexion and snapping. When I see that, then I try to use the ultrasound to determine, is this a lax volar plate causing the hyperextension and therefore the snapping lateral bands? Or are we seeing some degenerative changes at the PIP joint that those lateral bands are snapping over? It's hard. I mean, I'm going back to your technique where I'm, putting tons of gel on there and doing light pressure and going back and forth and seeing if I can see the snapping. I'm not 100% with that. Sometimes I get amazing images and it's like, oh, this is cool. And sometimes it's like, gosh, I'm struggling here. So, but just, on a normal routine, I'm not sure that I really look for the lateral bands. Yeah.
thank you.
Anybody have any other questions? That was really great. Really, really good overview and detailed overview of the extensor side of the finger. Protocols don't take a long time, and as you mentioned, ultrasound is really a game changer. So, all right, in 2 weeks, we're back at it. Dr. Schaff will be back. So thank you, everyone. Have a good Friday and a good weekend.
Thank you.